I'd like to call the next speaker, Kelvin. Thank you, Kelvin.
Thank you very much, Andrew, and that was a nice kind of overview of our unmet needs in treating neovascular AMD today, and really about this new generation of anti-VEGF that talk about durability. And I think what's really important and what BA has done nicely is to look at really longer term outcomes, so 156-week data from PULSAR. And this is really important in this generation of anti-VEGF, because here we're talking about drugs that can last 16, 20, 24 weeks. And you can't get these outcomes for durability in short trials. So it's very nice that Bayer went on to do this. Right. Here are my financial disclosures, and let's just go through quickly the PULSAR study, just a quick recap of how it was designed. So you had 3 arms, 2Q8. You had 8 milligram at 12 weeks and 8 milligram at 16 weeks. And remember, patients were randomized right from the beginning into these 3 arms. Primary endpoint was at week 48. Had another end of study at week 96. And then, of course, there was an extension into 156 weeks or 3 years. And this was an open label extension. Now, if you look at the essentially the results through year 2, you can see that the 8 milligram achieved these lasting vision gains and rapid disease activity control with relatively fewer number of injections. And those curves there are very nice, non-inferior to the control 2 milligram every 8 weeks. Now, when we talk about the extension study, here things get a little bit, things change a little bit. So essentially, everybody that went into the extension part of the trial had 8 milligrams. So if you started with 2 milligrams at the beginning of PULSAR, you were switched to 8 milligrams at week 96, and those that were at 8 milligrams continued on. In terms of their treatment regimen, those that were switched to 8 milligrams went on to a 12-week and then subsequently a treat and extend. And those in the 8 milligram arm continued with their last assigned treatment interval. So here you're getting into some very real clinical practice on how patients are being treated in the long term. And this is important because really when you talk about durability, it is out to these time points that we want to see how these drugs are lasting. So this is the treatment, essentially visits all the way up to week 156. I put up there the interval shortening criteria as well as the extensions. So remember, everybody started this extension at week 96, and everybody had these monitoring visits. So they had monitoring visits at essentially monthly intervals up to week 108, and then had quarterly visits all the way up to 3 years. Patients were allowed to have a shortened interval at any visit. So even at these monitoring visits, they were allowed to have a shortening of their interval, but they could only be extended when they were on a treatment visit. So remember, after week 96, everybody went into a treat and extend, and only allowed to extend during a treatment visit. So again, very reflective of how we practice. Of course, with these monitoring visits, patients were coming back much more frequently, but this was part of the safety of this extension study to ensure that we were not leaving vision on the table with this extension study. And if we look at the results, you see the good sustained vision improvement up to week 96 or year 2, and likewise, vision was maintained right through to year 3 in both the ones that were switched from 2 to 8 and those that continued on the 8 milligram arm. But perhaps what is more interesting is the number of injections that was given. Really, you can see a marked reduction in number of injections given in that second, third year period. Likewise, if you look at anatomical outcomes, you see, again, very consistent maintenance of central retinal thickness, and this really went all the way right up to year 3. Now, if we zoom into that group that switched from 2 to 8, remember they were on a 2 milligram 2Q8 right up to week, well, they had some extension up to week 96. If you look at this group of patients and where they were at week 96, you look at their retinal thickness, you see a marked reduction with that first dose of 8 milligram. This is a point of switch. Yeah? So point of switch, you see a marked reduction in retinal thickness. And we're all very familiar with the sawtooth pattern that we see in retinal thickness. And you'll see that in this particular group of patients, it takes a longer time to come back up to the peak of that sawtooth. So really driving home the point that having that switch to 8 milligrams, even late in the game, was able to give you some durability with anatomical outcomes. Like what the CRT was, of course, stable right up to year 3. Now, if you look at with the treatment intervals, you look at where patients were at the end of year 3, you see as well a large proportion of patients at the Q12, Q16, and Q20 weeks in this group. You note a higher proportion of patients in the Q24 at 8 milligrams. The ones that were switched from 2 to 8 really didn't have the opportunity to get up to Q24 at 3 years. We talked a little bit about safety, and you can see here that even up to year 3, the safety profile for 8 milligram was very comparable to that of the Aflibercept 2 milligram. And really, using this drug over the last year, I don't have any issues with the safety of 8 milligram, both from the ocular side as well as the systemic side. So key findings here from the year 3 extension, again, very important that these durability trials really go out and prove that it is long-lasting, beyond 2 years. You're getting maintenance of vision gain, better and faster drying, especially if you looked at that 2 milligram that switched to 8. And patients were able to maintain that treatment interval. So really, we're talking about patients having to require 3 injections, so every 4 months a year, out into the extension phase. I'm going to quickly go through a case here, and this is a patient from the PULSAR study. And I think this is a nice case because it's very reflective of essentially what we see in clinical practice. So this is, an OCT of a patient with neovascular AMD. And I would say it's serious enough that it's something that I might see in clinic. So it's not one of those cases that had a little bit of disease activity and was recruited into a trial. So this is, fairly reflective of what I see in clinical practice. So a patient was given the first 8 milligram, and you can see that there's still disease activity after the first shot. And again, very resonates very strongly with what I see in practice. Week 8 after the second injection, and then with the third injection, at week 12, you see all that disease activity going away. So if you look at a week 12 OCT, really it is returning almost to normal. Now, this patient was randomized to a Q12 week, and at the 20-week visit, you can see a little bit of that hyperreflective material returning, but really vision showing some good improvement. And as well, you can see that the central retinal thickness is maintained. And patient goes on to have Q12 treatment interval, and right up to week 56, again, that little bit of hyperreflective material is going away, and to me, a very normal looking OCT scan. At this point, there's an opportunity to extend this patient. Patient goes out to 16 weeks, again, very nice. CRT is maintained, vision is nicely maintained as well. Again, another opportunity to extend, so it goes out to Q20, and because anatomy was stable, vision was stable, was then given the opportunity to go to Q24. So Q24, this is 2 injections a year. And so this patient really represents kind of, I would say, a very generalizable example, because this patient was randomized into a Q12 arm, so not the Q16, so you didn't get the fastest extension. But even at the Q12 arm, you could see patient was getting out to 2 injections a year at the end of 2 years. I think most patients at this kind of treatment tempo would be very happy with the disease control, especially with that improvement in vision.